I am quite honored to tell you that in putting this program together, I had the best problem ever. I had too many volunteers for our panel. The talent that we have here today is remarkable. Loretta Downs, the president of the Chicago End of Life Coalition. Eileen Grace, a spiritual consultant and registered nurse. Reverend Dale Susan Edmonds, the creator of Talk Early, Talk Often. Jim Gould, an instructor of philosophy here at McHenry County College. Dr. Michael Marschke, director of hospice and palliative care of North Shore University Healthcare Systems. Barb Sutton, hospice and palliative care of Northeastern Illinois advanced practice nurse. And Reverend Tom Tews, a retired pastor from Emmanuel Lutheran Church. Does anyone have a question that they'd like to start us off with, or would you like the panel to start with a few thoughts of the movie? Okay. Would someone like to start us off with a thought or two about the movie? Or would you like? Dr. Mike, you started it very nicely the last time.
I don't know where to start. It is an amazing show. We should have really had tissues in the audience. It's a very hard subject, I know, for people who are in this every day to experience and listen to and talk about. And I think it's an extremely important subject. We don't do enough about in the country. And there's something that we outlined a number of important things that we should all be doing. One of the biggest things is just talking early, talking often, like the record has. The conversation is so important. From 18 years and up, we should really be talking about what it is that you value in life, what is it that is important to you in life, so that you can give what you love. Otherwise, unfortunately, we have a healthcare system that's going to take control, and that's what we're taught to do. So, I beg your pardon.
Yes.
So it is important to talk, because unfortunately the physicians, the medical system isn't taught from an early age on how to do this right, how to help people at the end of their life.
Thank you. Reverend Dale, what needs to change in order to help healthcare professionals deliver better end-of-life care?
Great question. I think there are several things that come to mind when you think about that. The first is that if you think about how people in traditional healthcare are educated, it is to save lives. You're trained, save lives, save lives, save lives. Death is a failure. And so to begin by trying to redefine that, to build into medical education that eventually all of us are going to die, and let that be an accepted part of the educational process. We're going to do our very best, and then when it's clear that the inevitable is going to happen, here's what we do next. And that part is not yet part of the standardized education. Second thing that comes to mind is that there's an element of medical care which is important, but when it comes to end of life ends up being kind of a hindrance, and that is the idea of objectivity above all, that I have no emotion, that I am not involved in this. And that gets in the way at the end of life because folks don't have then the skills to be able to have very difficult and delicate conversations. So walking in a room, okay, you've got cancer, you're going to die, see ya. It's not a proper conversation to be having with families at the end of life. So, that idea of it takes skill to have delicate conversations with people and And so those communication skills being a part of education. And maybe instead of waiting for the educational system, the medical educational system to change itself, is that all of us can do the work of empowering patients and families to ask new and better questions that help the medical professionals to engage in the conversation. It's like, let me ask you this, what about this? And the more that we can engage them, begins to change the whole, I think, direction of what happens next.
Thank you. Can I speak to that for a second? Can you hear me okay? Both my father and my grandfather were cardiologists, and we've kept several of their books that they studied with. And I actually found a book on communicating with your patients. It was my father's. And he's been dead for several years. He would have been 80. It's about the size of a paperback, teeny tiny little book. And now you have to remember, there are a lot of physicians who are probably just ending their practices now, who grew up with this book, who went through school with this particular book. And basically, the essence of this very, very small book is patients don't really want to know. You don't need to tell them everything. I can certainly talk to more of this, who went through medical school. But that generation certainly was not getting the education that they need to speak to their patients about serious illness, end of life, that I'm sorry you're going to die, we are all going to die. It was really startling to read that book. And I know in my own education, both as an undergraduate nurse and as a graduate nurse, advanced practice nurse, we didn't get very much education on how to speak to somebody. I got that more in my practice and working with physicians like Dr. Mike and Dr. Twaddle and other physicians on how do I have that difficult conversation, because school certainly wasn't preparing me for that. I looked up some research the other day, just pulled off a PowerPoint, and in one survey question, the 20 most difficult questions that physicians have to respond to. And again, I'm speaking for physicians, sorry. And they asked, would you withhold information about a serious illness from a patient if you thought that would be detrimental to them? Didn't say what they thought detrimental meant. Fully 60% of the physicians polled said yes in one form or another. They would deliver it gently. They would not give the full information. They would give it over several months. At least according to that survey, all of us are still being very, very, very fearful of helping have a conversation with people and initiating a conversation.
I think when part of the conversation is listening. Lots of folks, my experience is lots of folks are willing to talk about it. What death is dying is all about, except then people forget to listen. A couple months ago, I just had one of the most incredible experiences I've ever had doing work at a hospital. I'd seen this lady numerous times through about a 6-month period, because I was there that many times, and doing chaplaincy stuff. And I walked in a room one afternoon, and the daughter was there, and she said, "It's just amazing you walked in, because Mom has been talking. We decided her pastor should come, or the chaplain should come in, and you walk." And Mom had been ups and downs with medical stuff, and the future wasn't long-lived, except the family didn't want to talk about the issues. And so I said, "What have you been thinking about?" She goes, "I'm in Egypt." I said, "Egypt?" And this woman at that point looked really tired and pale, and I could hardly understand her. And she said, "I'm in Egypt, and I'm trapped." Ooh. I thought, okay. You want to get out of Egypt? Yeah. Maybe it's okay to get out of Egypt and go to a new place, huh? Yeah. The longer she talked about it, her eyes brightened. I had no problem understanding her. And the daughter sat there and looked at me and said, "Have you ever seen anything like this before?" And I said, "No." All she needed to do was have somebody listen to what she was thinking about. The next night, her husband was there, and I walked in and she said, "Again, I've been thinking, I feel trapped. I'm a teenager. You want to go? For a walk to a new place?" Yeah. Got the husband outside of the room, and he said, I said, "That's what she wants." And he goes, "She's confused." And I said, "Sometimes people they decided it was okay to do POA stuff that next day. And she died a real peaceful death a couple days later. It's how do we listen to what people are saying, even when we don't know, have the foggiest idea. I didn't have the foggiest idea what she was talking about. All I was she was talking about Egypt to begin with. All of a sudden it dawned on me, Egypt is a land of bondage. Sometimes it works out right.
Thank you. Thank you. Eileen, what typically happens when patients don't prepare for end of life?
Well, I think the biggest thing that happens when people don't prepare for it, like there can often be a lot of drama and distractions around the event, and it takes us away from what is actually happening at the event. I think for most of us in this room, I think our healthcare providers, for those that aren't, when somebody dies, it's a very meaningful, very powerful event, and I like to liken it to the birth of somebody. We can all rally around the birth of somebody, get excited and appreciate the event for what it is, but when somebody transitions through death, we make it something really frightening, and there's so many beautiful healing things that occur at that time if we're open to it. But if we don't prepare for death and we're not talking about the likelihood of it, and we're not doing all of those little tasks that maybe have to get done, that's what becomes the focus, and we miss the whole experience. It's like being at a wedding and sitting in the bathroom or something, you know. There's really a lot going on, and so we rob ourselves, we rob our family members, we rob our loved ones of a time that I believe is the most healing in this lifetime that we live, is at that time when maybe we're not going to live, maybe the cancer is going to, you know, be the way we exit this earth, but we can heal our relationships. We can say to our loved ones, I love you. We can forgive each other. There's so much good work that goes on. So that's why we need to prepare. That's why we need to do it early. So when it's not so stressful. And, you know, kind of adding to what Reverend Dale Susan said here is that with education, I do a lot of work now speaking to community people, individuals, and most of them do not have advanced care planning work done, advanced directives drawn up. They don't even know what they are. And it still surprises me. After doing this work for so long, I still get surprised when I talk to 30 people and I ask the question and 2 people raise their hand that they even know what it is. But then I look at all of us, and I want to ask all of you, how many of you have gone through that process yourself? Because in order to educate, we need to have that understanding of what it's like. And I have done advanced directives, but most recently I had to do it in a very different way. I'd done it because I was a hospice caregiver, and I thought I should. And I went through the motions of getting those papers together. But last year I got very sick, and I redid my advanced directives from a standpoint that I might not make it, and it was very clear that I might not make it. And I have to tell you, going through that process of what everybody that you care for has at some point gone through was incredibly moving to me. It changed my life. It changed everything about how I approach life. So I would encourage all of you as educators, and if you're not an educator but just a community member learning about this, please do the work. Go through the process. Do it now. Do it when you're not faced with, am I going to be alive tomorrow? It's a very enriching experience.
Thank you. Loretta, what's an advanced directive, and how does the tool help patients and families prepare for end of life? Is an advanced directive adequate, or is there more to do?
An advance directive is, it's a legal paper, actually, and in 1990, we all were given the Patient Self-Determination Act by the federal government, which allows each and every one of us to refuse any medical treatment that's offered to us. It's a right we have. And this right came to us because of 2 young women under the age of 25, Karen and Nancy Roseanne, who were in persistent vegetative states in their
It's something that merits a conversation. I know people that fill these documents out with attorneys, spend a lot of money, and then they get filed in the safe deposit box where they're like useless in the time of need. So the power of attorney for healthcare is critical. Even more important, though, is the conversation about your wishes. And the second legal form that that would apply to would be a living will, in which you specify things like the kinds of treatment and how you want to be treated at the end of your life. But the conversation, as the film has really, I think, made clear to us, is so critical. But we do have advance directives, and there you can redo them as often as you want, as Eileen has done, as I'm on my third. So they're important for us. And I often say I wouldn't drive a car without wearing a seatbelt or having insurance, and I don't want to walk around in a body today without my advance directives in place.
Thank you. Jim, would you like to comment on advance directives?
I think it's really important to emphasize sort of the point that you got to at the end, which is that the really important thing is the conversation. This interesting research coming out of, I think, Oregon a couple of years ago, where they asked people, have you filled out an advance directive? And all these folks said, oh yeah, where is it? Somewhere at home. Did you talk to your kids about it? Long pause. And the people would say, you know, I didn't. It's a really hard thing to talk about. Did you share it with your doctor? No, that's private information. And what the research tends to show is, if you've done the paperwork but you haven't had the conversation, you're not going to be as well protected and looked after than if you haven't done the paperwork but you have had the conversation. By Illinois law, if you haven't appointed a person, there's a laundry list that it'll go automatically to your family, even if you haven't filled out the paperwork. So I really do think that it's having that conversation. And those are not easy conversations. 4 years ago, my brother-in-law was killed instantly riding his bicycle on Memorial Day weekend and was hit by a passing motorist. And over the last 4 years, my wife and I have had long, lengthy conversations about what would we want done in the event that medical decisions had to be made for us. So these conversations are not just hit and run. They're long and lengthy.
Thank you. Dr. Mike, you have a saying about the 5 Ds. Would you share that with the group?
Well, that's when we feel you should readdress and look at what your wishes are, what you value in life. And it's around, now you got me challenged because I get all 5. Death, if you have a decline in your health, so death in your family or loved ones, so it sort of brings this to mind. If you have a decline in your health, if you have a new diagnosis made every decade, and then last is sort of my favorite because the the Surrogate Act in Illinois lists the number 1 is your spouse. So if you get divorced, that's the other D, you should assign that to someone else, otherwise your ex may be in charge of you.
Making decisions.
But so it's just reminders of when you should do this. And in my mind, it's anyone who's 18 or up should be having this conversation. And you know, it's different scenarios. The 18-year-old, those are the ones that make the news. The Nancy Crisans, the Terry Shivos. These were young, healthy people who had a catastrophic event. And who's going to make your decision for you? Who do you trust that's going to make your decision for you when you can't? That's the crux of the issue. Not necessarily just end-of-life stuff. It's feeding tubes, it's surgeries. Someone's going to make your decision for you when you can't because you have a condition that makes it hard for you to think these through. So who do you trust to make these decisions? And the big second part of that equation is, do they know what you want? Because being in that decision-making role, when you don't know what the other person would want, we've studied this, and it equals the stress of your own house burning down. So it's a very stressful role. So this is a gift. Consider this a gift to your loved one who is going to be in that role. God forbid when that occurs, but it could happen tomorrow for each and every one of us. Give them a gift of love, trust, conversation, your values, what you would want, how you want to be treated, however long that is in that declined health condition.
Thank you. Thank you. We have a question back here?
I could probably shout. Okay.
Okay.
I just wanted to know what your standpoint is on 5 Wishes document.
The 5 Wishes is a good tool. There are lots of tools out there. 5 Wishes is legal in the state of Illinois. So it's just another tool out there to help express your wishes, and this is a way to write it down. Nothing, though, is more critical than the conversation. So if you use that tool as a conversation, just don't, fill out a 5 wish and hide it away, because that gets to be useless. Yeah, your loved one may be able to find it and pull it out and say, oh, this is how you want to be treated. The 5 wishes goes through 5 different sort of things that you would want, how to be treated, how you want to be valued at the end of your life. It's just, to me, it's a useful tool to have more of the conversation. There are other tools out there. I sort of like this Go Wish game. It's a card game, which sort of you can go online and buy for $5. But it's like, what things do you value in life? I want to be at home. I want to be in the presence of my loved one. I want to be touched, or I want every last thing done because I value quantity over quality. So those are the types of things. So this is not necessarily like, and I think too many people sort of view this as the medical system are promoting these death panels so that you don't get this stuff. That's not what this is about. If you want all this ICU stuff, all this stuff, you should be able to get it. But at least have that as part of your wishes, if that's what you really value. It makes it a whole lot easier on your family when these decisions are right in front of them. Is that, oh, that's what you want? Let's do that.
Okay. Thank you. Eileen and Loretta, you both had something?
The one thing about the documents, there are a lot available, and if you go to the National Healthcare Decisions Day website, which is nhdd.org, you can download the Illinois statutory forms free and some terrific American Bar Association workbooks that'll help you have this conversation. The 5 Wishes does cost something, but this is an intimate conversation, and it's an ongoing conversation. And one of the things the 5 Wishes does is give you some very good points to discuss with your loved ones. And the bottom line of these conversations is that you will grow closer to the most important people in your life, the person you trust to make these decisions. So I encourage the conversations from a spiritual aspect, because death is really, it is a spiritual experience. It's got medical implications. And we need to be touching that part of the end of life.
Yeah, I just wanted to share a story of somebody that I had talked to about doing advanced care planning with a loved one. And what Dr. Mike said and Loretta just supported is the importance of the conversation, but it doesn't have to be as scary as sometimes I think we think it is. And this one woman had talked to her father, who was having early signs of dementia, and she knew that the course was going to continue, and was not a medical person, didn't know how to have these conversations. And we talked about the importance of who he was and his values, and if you could have conversations around that. And after several conversations with him, it came down to what was important to him was he loved to sit by his window and watch outside the backyard and watch the birds, and if he could get up and do that, that was a good day. And the other thing that was really important to him was his chocolate ice cream every night. And if he could eat his chocolate ice cream every night, for him, that was a good day. So as his disease progressed, she based all of her decisions, when he could no longer make those decisions for himself, on those 2 values. Can he still get up and look out the back window and enjoy his backyard. And then when it came time for a feeding tube discussion, because he could no longer swallow, she clearly knew that this is not what he wanted, because he couldn't eat his chocolate ice cream. So sometimes we make it harder than we have to. There's no better person than someone you love and trust to really know who you are and what you value. So those are the conversations that need to be had.
Yes? Question?
Whoever wants to answer this, how do you talk to or work with family members that disagree with what the power of attorney has decided based on what the patient has wanted long after the patient, as you indicated, is lucid and cognizant? How do you work with that when everybody else has a different approach, different wishes, different thoughts than the power of attorney? How do you deal with that?
Sure, Reverend Dale.
There's kind of two things you have to bracket out, I think. One is the legal aspect, which is, at least in Illinois, power of attorney is the one who really is calling the shots. So you got the legal aspect. Then there's the whole emotional family dynamic aspect, which makes all of that group very, very important. And part of the work is being able to have enough time to be able to listen to all those individual voices in terms of what's behind the stance that they're taking. It's not just a fight about medical decisions or which medical procedure. It's all of what does this person mean to me and what's at stake for me. And so it's working through that emotional part and giving them the space to listen and really be able to get in touch with the grief that they're struggling with and articulating all that. The other piece can often be an educational piece. That we have, for instance, tremendous emotional content around feeding people. And if someone's no longer able to eat, well, of course they've got to have a feeding tube, you're going to starve them to death. So the education around what does this really mean, medically, in terms of a person's body, when their body physically is no longer able to process food, what does this medical technology mean? And not only today, what will it mean, but what's it going to look like tomorrow, a week from now, a month from now? What are the consequences of this decision? And kind of doing both, the educational piece and the emotional work. And then often people find them moving from that hard and fast place that they started with.
Thank you.
It's work. It's not one conversation sit down in 10 minutes and everyone's in agreement.
Reverend Tom?
One of the difficulties is sometimes there's not enough time to do the educational stuff. And I usually tell folks something along the line, there's nothing like weddings and funerals to bring out all the family dysfunction. And for people that know me, one of my gifts is not beating around the bush. And I'll just lay the stuff out, like she was just saying, as succinctly as I can. And bottom line is, even though you don't like it, the POA has the final say. And sometimes, you'll have to deal with all this stuff later as part of the grieving process. And that's why, again, going back to the very beginning, it's important that people talk about this over and over and over again.
Thank you. We have another question.
Long-term care for a long time. And one thing that I have noticed is that the importance of early conversation can't be stressed enough. What I have observed is that we have patients who have said they don't want anything done, and yet when they're in the hospital, because the POA does not agree with that, they have pushed for tube feedings, intubation, and all sorts of things that the patient never wanted. So I think we have to use this early on conversation so that the power of attorney is aware of what the patient's wishes are so that these sorts of things don't go on.
Panel, any comments to that?
I agree with you, Mary. I think we do need to have the conversations early. And as healthcare professionals, I think we need to educate families
the role of a POA and how important that role is, and that you pick somebody that really is going to be able to advocate for you, put their own agenda aside, and really be able to be that person that's going to stand up and maybe in some circumstances fight for what you want. So the picking the POA is extremely important. Too often I think we see family members just kind of defer to the spouse or the oldest son, and not really put a lot of thought into what that role could end up being. So we need to educate more on that as well.
And I'll tell you a personal piece to support what Eileen has just said. My husband suffered much loss as a child. He is not my power of attorney because I know he couldn't make the decisions that fit me. Pat, you had a question?
Oh, I do? Okay.
Oh.
Is it still considered legal if somebody who has dementia, who already has advance directives in place, to change them at some point?
You have to be capable of making decisions appropriately to be able to change the document. It depends on the stage of dementia. If they're severe enough and incapable of reasoning why they would want to change that advance directive, then no, they couldn't do it. And that has to do with legal, the legal definition of competence, which would be a court thing that would be determined by lawyers, that if someone was incompetent, they couldn't change legal documents.
Yeah. And the only way that a change could be made is if someone legally got guardianship of that person, and then the guardian has power over any previous legal documents that have been made. But that's a complicated and expensive process to get guardianship.
Jen, we had a question up here as well. Barb?
Educating, am I not loud enough? Usually I'm very loud. The importance of educating the patient, the family, primarily the patient, about the choice of POA. That if they're siblings, and you have to educate that person tactfully and kindly that the one that you want is your strongest advocate, who will be able to stand up with the family dynamics, because it's not easy. And everyone responds to grief in a family and the loss, and old issues are brought up, and it can be either the most beautiful time at the end of life, or it can be an extraordinarily difficult time at the end of life.
Yeah, you bring up a good point. That you know, we talked about family discord and whatnot, but the conversation, the gift to your family pre all this stuff, where you're telling them, okay, Joe, my second oldest son, is the one who I value, and this is the reasons why. It'll help the rest of your family be more in harmony I mean, it's a very stressful time when your loved one is sick and in the ICU or in the hospital. It's a family thing, and one of the physicians in the on the film said that. It's the family practitioner. It's a family. This disease doesn't happen in isolation. It's a family disease. So the gift you give to your whole family pre all this stuff is a little bit more calm, a little bit more direction, a little bit more understanding for them all, to understand where that power of attorney is getting all their direction from.
Reverend?
And just one other word, in addition to the importance of choosing the power of attorney, is the in the conversations with the power of attorney, is the education, both of the patient themselves, but the education of the power of attorney to what that role is really going to entail. Because there are, as a hospice chaplain, the number of people that, oh, you make a phone call, use the power of attorney, blah, blah, blah. Oh, I am? Really? They're surprised by that. Or they're, in the midst of different conversations, really surprised by the level and the gravity and the difficulty of the decisions. So that part of the work for all of us is in naming a power of attorney, giving them a context in which these decisions are going to be made. For instance, the decisions for a cancer patient are are going to be very different than the decisions for a person with Alzheimer's, which are going to be very different than the decisions for somebody with kidney failure, very different from decisions with another disease. Every disease has their own kind of way that it's going to progress, and different decisions that are going to be made along the way. And so the earlier that kind of picture can be kind of painted, and the conversations obviously involving your doctor and your healthcare team with the patient and the POA to kind of get the idea that, hey, this is going to progress, there's going to be some hard stuff coming, and here's the kind of things you're not going to be thinking, you're going to need to think about. And sometimes that's where our advanced directives and sitting in the lawyer's office can really be a hindrance, because it's, we get the false sense that, okay, I've signed the papers, I'm done. You're not anywhere near done. That's just the opening the door to the first conversation of which they're going to continue and continue and continue.
As another piece is, we've been talking a lot about the role of the family and about family getting their house in order. Part of what I see as a member of the ethics committee at Integra is the disarray within the medical community in terms of its communication. So we can have all the plans in place, but if I'm getting fragmentary information, and way too often what would happen is, let's play out a scenario, so my dad's in there suddenly, and my sister is there at 7 o'clock in the morning, and the pulmonologist is rounding, and she hears the lungs are shot. And I'm there at noon, and the cardiologist is rounding, and she's like, he's got the heart of a young man, and my mother's there at 3 in the afternoon, and here's another piece from the kidney doc. Nobody's getting the full story, so you could have done the most wonderful advanced care planning. So maybe part of the education that needs to go into the POA is you're going to have to really push for clear communication from the medical team. So there are these two poles that both have to be in order, and things can go badly because of miscommunication in both realms.
Thank you. Pat?
As oncology nurses, we have run into problems with oncologists who say, don't say anything to the family, don't say anything to my patient about hospice. And literally, we've had people that have died the next day after the oncologist said, I will take care of it, or I'm not going to talk to them about it. How do we get around that and being able to talk to our patients?
Ooh, they're all stirring up here. It's a good.
That's
a good one, Pat.
I should probably start because I'm the only doctor in here, but we have a couple big barriers in our system. One of the biggest is the physicians, and there's a number of reasons that is. The first off is in medical school, we are taught to fix things. We are taught to heal. We are taught to treat a disease and make it better. We are grilled that death is a failure. We actually have rounds, we call them M&M rounds, it's morbidity and mortality rounds. We have these things monthly, which says, essentially is saying, okay, your patient died, what could you have done better to prevent that? Which to me is the biggest oxymoron there is, because the only 100% in medicine is that every single one of your patients will die, unless you die first. Guess which profession in America fears their own mortality the most? Us doctors. So we've got a big barrier here. We've got an educated group of people who are in charge of this stuff, and they think they're in charge. And so even though the physicians may complain about it or gripe about it, it is really the patients that should be in charge. So it's a matter of trying to empower the patient, empower the public to really take control, which means that they have to know what to ask, what conversations to have. If they're not getting the right answers, they have the right to get other opinions from other doctors. Unfortunately, doctors are good at yelling and screaming and sort of saying that they're right, which is not right. So you have to empower the patient, empower the public to help get through a lot of these barriers that you get. Now, we are getting better at it on a nation level, meaning that the oncologists are being taught the value of palliative care, the value of hospice, and more studies are showing that palliative care is actually not exactly about the end of life. Good palliative care actually is now showing in studies to actually prolong life, just as much as chemo can, third-line chemo. So we are actually focusing on quality, focusing on comfort, and getting the oncologists to realize there's much more of a value to this stuff than they actually think about, that they actually know about, but they're only focused with narrow eyes as the chemo, that there is something more out there. So it's a matter of education and empowering people.
Barb, would you like?
Just a brief comment. I was at a conference for palliative care a year ago, and the president, Dr. Diane Myers, related a story about a patient that she was caring for who was having about I can't remember what cycle of chemo, but very, very end stage, and was clearly dying, was not going to receive benefit from the chemo. And when she called and asked the oncologist, "Why are you giving this lady more chemotherapy?" his response was, "How will she know that I care if I don't do that?" You know, and that's one thing, having grown up with a father and a grandfather for physicians, I remember very clearly, and I'm sitting next to a very human physician here too. Doctors, nurses, you know, we're all human too, and we're scared, and it's hard having a difficult conversation. And we don't, many of us, don't want to be seen as abandoning our patient, or we don't want to be seen as abandoning our patient, but we don't really know how to give bad news in a way that doesn't sound like abandonment. I saw a young lady with a very advanced vulvar cancer, and she had been told by her doctor, who'd been caring her oncologist, who'd been caring for her for 14 years. He walked in and he said, "Well, there's nothing more I can do for you. I'm going to have the nurse talk to you about hospice." Now, whether he said those words, I don't know, but that's clearly, again, what she heard. She was devastated by it, and then she'd also been told, or gotten the perception somewhere along the line, that hospice wasn't any good because all they did was hold your hand and tell you you're going to die, which didn't help very much either. So this poor woman felt completely abandoned by everybody who ever could have helped her. And that all comes back to education, you know, that we need to educate everybody we talk to, whether it's the oncologist or the cardiologist or your mother, my mother, everybody. It's talking about how important it is, kind of down to the nuts and bolts, to talk about the fact that 100% of us are going to die, and how do we want to do that? How do we want to maintain some control of that?
Eileen?
Yeah, in response to the oncology nurse question back there, I started out as an oncology nurse, so I really know the dynamics sometimes that you're placed in. And I want to say to you, first of all, it aggravates me, because I think if that was me, I don't think any physician has the right to take away from me my last days or weeks to make decisions that I feel are appropriate for me and not what he feels is appropriate for him. So that angers me, but there's no short answer to how we're going to impact that by tomorrow. So what I would like to suggest is, and what I do as much as I can in my practice, is to really empower patients, to really encourage them and to remind them that they really are in the driver's seat, that it is their life. If you're feeling uncomfortable about a decision a physician has made, then to empower them to talk to him about that, to talk to their family, and as much as you can, support them to be advocates, the family and the patient, for their own health and well-being. And having said that, for anyone that works in hospital systems right now, by the time hospice caregivers get the patients, most of them have advanced directives in place, for the most part. But in the hospital system, as a person of a hospital situation for the last 12 months, I was in 4 different hospital institutions, and over many times, and I had my advanced directives. I was quite proud. I had my little package every time I went in there, and I was really taken back by how poorly the systems handled that. I would say, do you want my advance directives? Oh, no, we don't need those. I was told, we just need to ask if you have them. We don't need them. I was like, well, what good is it going to do if the check mark says I have them? Now, luckily, my power of attorney was my sister-in-law, who's a nurse. So I wasn't like in great turmoil over the fact that they wouldn't take them, because she was with me at every critical step. She knew what I wanted. So I had some peace of mind, but it was very disturbing to me because as somebody that's pretty strong in the medical system and willing to stand up and say what I need to say, I thought, how about all of these people, these 70-year-olds who are coming in who don't even know what to ask, who don't even know the right thing to do. We as healthcare providers need to be better about honoring this piece of someone's healthcare. We're doing a really not bang-up job. So I encourage all of you to really support that and talk to your patients about it. Ask them. Maybe people were intimidated to ask me if I had them. You know, maybe she thinks she's going to die. Well, I already knew I might die. You weren't telling me anything special. When our patients, our oncology patients, bring up a concern, they know. I have never worked with a dying patient yet that didn't know they were dying, that said, oh, I'm surprised. They knew. They told me, oh, I know this is going on. I just wish someone would talk to me about it. So we really have to be good advocates for our patients and our families.
In my clinical practice in the oncology world, when, just as Eileen has stated, people do know, patients know, and they look to you with that want in their eye, you ask, what are your goals? And it's amazing how you've empowered them, and then they're more comfortable to speak to their physician. There's a question? Oh.
Excuse me, I had a question. My mom just turned 60 and my dad's 58, and they're, spring chickens still. But I tried having the death conversation with them many times, and I myself have a very hard time with death. I don't like to talk about it, but I, of all my siblings, will probably be the one to choose once one of my parents are gone. I would think they would leave me in charge. How do I bring it up? My mom called a funeral home. That's as far as she got. She wants to be cremated. That's all I know. I've tried the conversation over and over and over again, not really sure where to go from here.
Congratulations, your mother at least has decided where she wants to be buried. A lot of people don't get that far. I have two suggestions. One, this 5 wishes is a great little guide, because when you say, let's talk about it, you don't know where to start, what questions to ask, because we don't do this. We don't get to practice this. Your mom and your dad are going to die once, most likely. So having something in writing that you can use as a guideline. And another way to start the conversation when someone is resistant is talk about your own wishes. You say, Mom and Dad, if I'm in an accident, you're going to be asked to make these decisions for me. And right now, we're all healthy, so we're only facing an accidental or an emergency situation, and I'd rather be prepared and save us a great deal of suffering than not be prepared. And make it easy. Do it order a pizza, open a bottle of wine. Really, use a teaching moment. When you see something in the newspaper, and more, I'm noticing in a report on an accident that so-and-so is on life support. It's happening more and more that people are in emergencies getting an extension of their life on life support, and the issues of organ donation are part of it, and families being able to come in from long distances. So someone said earlier, make it simple and just comfortable, and you can start with a couple of big decisions like, well, where would you want to be cremated or buried at least? And where do you want to be? And well, gosh, what if you're in the hospital and maybe life support's an issue? What do you want? Just like that, and keep having this conversation.
Excuse me. One of the other things that I've used to help people start having that conversation is asking about family members or even TV programs or movies that they've seen. What kind of situations did they see in those instances that your mother or your father had a comment about? That I'd never want to be that, or just something that's not real right there to them, but can start a conversation as well. And getting a bottle of wine, and actually that's how I initiated 5 Wishes with my own daughter for myself. She was very reluctant, so I went out and got some wine and Chinese food, and we actually watched the 5 Wishes tape. It was long enough ago, so it's still on tape, not DVD. and ended up having a rather riotous evening, but got a lot of discussion going with that. It was very effective.
Another thing too is that there's a lot of publicity about having the talk. It's not a talk. It's a lifelong conversation. And so the idea that you're going to sit down once, write it all down, and we've done it, okay, good, that's over with, it's not true. And so, you might look for openings like Loretta was saying. You may just, snatch something that's a 5-minute conversation that's going to get you some really valuable information. And also to make sure that your ears are opening for the clues that are there, that somebody just might drop in and to seize the moment. My aunt called me one day a couple years ago. I live up here in Chicago. She's in Kentucky, and my aunt never had children. We were talking about something else, and she says, oh, by the way, when I'm really too sick to take care of myself, I'm moving to Chicago. So you can take care of me. And switch to something else. And I went, whoa! This is fascinating. Okay. Clearly we needed to have some conversation about what was next. But we were getting all kinds of, my mother one day, in the middle of a conversation about something else, said, oh yeah, my parents live in Atlanta. Said something about my dad wanting to be buried in the military cemetery in Kentucky. And it's like, really? And so we had, I took that, filed it, because she went on to something else, which was her way of saying, that's enough, I can't handle it anymore right now. But I filed the information, and at an appropriate time later on, was able to swing back around and kind of, have another little bit, but it's kind of like capturing each one of those moments. And what's also important is finding a place that you've got a notebook or some place, a computer file, but where you're recording that information. When you had the conversation, what was said, because you can forget, but also be able to then have the conversation with your siblings. It's like, oh, by the way, mom said this to me, or dad said this to me, or whatever, so that more people are brought into the conversation and can be participants in that expanded dialogue that goes on.
That's what we get. We get little tidbits. It's not, and I'm trying to file all of it, but it's hard when it's kind of like, oh, I have too much to do now. I'm not going to die tomorrow kind of thing. That's the hard part, is that it's never really a 5-minute. It's the little tidbit like your aunt.
Keep taking them, and you look for opportunities, whether it's the movie, whether it's, a friend's like, oh my gosh, my friend's mother's having surgery, and you ask a couple of, they're really struggling with this. You ask a couple of questions. So every opportunity that not every time, they don't want you don't want them looking at you going, oh no, here she comes again. I don't want to go that far.
You can use your attendance today as a forum as well.
Right. Watch this movie together.
There's a question up there.
Hi. I was reading a research article recently that said that Americans are the worst at dying. I know other cultures, they kind of celebrate death and whatnot. What can nurses do to change people's attitudes in this country towards death?
Well, I think you hit it on the head, is to encourage it to be a celebration a little bit more, but that's a far stretch to come from where we are today. Americans do fear death greatly. They believe it's not going to happen to them, and unfortunately we're in that period now where the baby boomers are of age, and that's the hugest segment of our population, and they are dying. But most of them believe they're not going to. They're going to be infallible. So I think that just not to, as healthcare providers, not to shy away from the conversations. And this has always been important to me, working in hospice. There's many disciplines in hospice. We have the chaplain, we have the social worker, we have the nurse, we have the CNA, we have volunteers. We have a lot of people in with the care of a patient. And what would bother me most is there's going to be someone that patient is going to connect with and to form a trust with, maybe over other caregivers. And I would have nurses tell me, or I would hear from them that, oh, Mr. So-and-so started talking about a DNR, but I told him the social worker would come in and talk to him about that because that's her job. When patients feel trusted enough to open up a conversation, we all need to be comfortable to sit down and have it with them, because the moment they open that door and start to be vulnerable enough to share with you may be that only moment. And if you close that door and say, you know what, in a week, Susie, the social worker, will be in, she can talk to you about that, well, you may have lost that moment. And we do that too often in healthcare. You know, I'm busy or I'm uncomfortable with it. So in a short way, as healthcare providers, you need to get comfortable with dying. You need to get comfortable with your feelings about that, with your views about that, and not necessarily to share with a patient. It may not be appropriate to sit down and share with a patient what I believe happens after we die, but I am very comfortable with that in my own spirituality, that if someone else wants to talk about what their beliefs are, I can sit comfortably and listen and create a safe space for them. And that's what we need to do much more of. And it's about our own personal and inner work that we are called to do in order to be better caregivers and minister to our patients on that level in a better way.
I was wondering if you could make some suggestions on how to communicate with families who don't want the patient to know what their prognosis is, or
Oh, they're not squirming over this one.
The patient is the one that has the right to know everything. So there are lots of, and some of this is cultural, but some of it may not be cultural, where, you know, don't tell grandma what's going on, the bad news. You know, that's okay if that's what grandma wants, but let's go talk to grandma. So let's go in the room, and I want to ask her, the patient, how she wants to receive the news. How does she want to understand what's going on? If she doesn't want all that news, then I have to value that as a clinician, and okay, who do you want to know? So that's one thing that we're not good at in the healthcare field, is asking patients how they want to receive all this information, how they want to receive the bad news. And the only way to do it is ask. And if that's what they want, that's fine. It's the minority of people, less than 1%, would want that, but there are people that do. But we have to respect the patient. So we have to bring the family into the room and have the conversation about that with the patient so that we can understand and be on the same page. A lot of times it's, oh, the patient, you know, the family wants to protect the patient, but the patient's, no, that's what I want to know everything. So then we get them to hear that from the patient.
Anyone else?
After 25 years of being around healthcare decisions, it strikes me that most of what goes on, probably 95%, is not about ethics. It's not about religion. It's not about law. It's about two things. One I talked about earlier, which is poor communication within families and poor communication to families from the healthcare system. The other is it's all about unfinished business, and I think you had talked about that earlier. You know, it's about, you know, I'm not ready to let my dad go yet, and so, you know, what is it that's going on within that family who is saying, nah, you know, we don't want you to tell our dad. That's what their unfinished emotional business.
Barb, you had a question?
I'm just going to say something really quickly. I think the one specific instance that Mary is talking about is the woman and the patient actually has a level of dementia, and her son's trying to protect her from any knowledge there. Now, I don't know, and that always throws in another a curveball, absolutely. And one of the examples that I've dealt with that was similar to this, Mary and I talked about this before, so I've had a chance to mull this over a little bit, this particular instance. But I saw a gentleman at home who had an adult, a normal pressure hydrocephalus, and the neurologist had said he had a 55% chance of getting better with shunt placement. Not sure how he came to that number, but so the family was, torn on how do they decide that they want to put their dad through this surgery for 55% chance of getting better. And they had no healthcare power of attorney. They'd never had discussions. He had been resistant, whatever. And I actually I sat down with a piece of paper and drew a line down the middle and had pros on one side and cons on the other side. And we went through decisions he'd made about his healthcare. Oops, sorry. Okay. We went through decisions he'd made in the past for his own health care, including the fact that he had turned down any investigation of an elevated PSA for his prostate. He didn't want anything done there. He turned down several procedures and diagnostics in the past. And when the two girls started really getting through what he'd gone through, his decisions, they had a list about that long of all the things he'd never wanted to have done in the past. He'd had his appendix out, and he'd had some wisdom teeth removed. Those were the two things he decided to have done procedurally. So they looked, I didn't have to say anything. They looked at me and said, he told us, just in a different manner. So that's how they came to that decision on helping him, which veers off a little bit. I don't know how you get to, dealing with family members with a demented parent, beyond that when it comes to some kind of decision.
No, how many of you have been decision makers for someone already? Okay, and those of you who have not probably will be someday. We do the best we can. The desire not to make a mistake cannot overpower us making a decision. And the decision you make is based on something. You're weighing the information you have, you're trusting the people that you have to trust who are before you, and you consider all the circumstances and discern the right decision, and then you have to make a decision and accept that. And I think one of the things one of the things a lot of family members deal with is guilt after making a decision and did I make the right decision? And we have to let go of that. You just do. And hold the fact that these are acts of love we perform. Terry Schiavo's parents and her husband were expressing love for her, although they had opposing positions on how to express that love and care for her. So whatever you might have done, you did the right thing, and anything you're going to do, approach it with as much information as you have, and just trust that, just trust.
Barb, you had a question?
Another thought too, in terms of that, I like that, love that idea of the icebreaker kind of thing, but to kind of gauge the kinds of conversations you have every day, it's very difficult if the only thing you talk about is what'd you have for supper and what'd you watch on television, to all of a sudden then jump into a conversation about, and what do you want to have done, when you can't make decisions for yourself. That's kind of a big gap. And so you might have some other incremental conversations that get you in the habit of having more, more intimate conversations, 2 conversations that really do indicate that you know that they're going to die, and 3 that place you in a position of being a partner with them and on the same team in terms of making those decisions. Now, for example, a simple thing that I did. Recently went to a birthday party of my godson, who's only 12. But it was an extended family. His grandparents were present, his parents. His grandparents are getting much older, not necessarily in the best of health. The gift to him was a recipe book, but then a notebook where he could record recipes in it. It was blank pages. And I said to him, this will be a really great thing, not only to use the recipe book to start cooking with your parents and learning how to cook, but also to talk to your grandparents and start writing down some recipes, because they may not be around forever. And so just that message that, guess what? They're not going to be around forever. Start recording some things now, having some conversations now. So it may be around the house. Gosh, that's really a lovely piece. So who do you want to have that when you're gone, so I don't have to fight with my sister? Asking some questions about, I wasn't around when great-grandma died. How old were you? What was that like? What were you told about, this or that? So that it can be non-threatening kinds of things that you get practice with having more meaningful conversations, and then you can work into deeper and deeper and deeper subjects over time.
There's a question.
Yeah, this is a question for our clergy folks. What can we do as clergy, our churches, our synagogues, our temples, our mosques, to encourage this conversation about end-of-life issues? Thank you.
Reverend Tom? $1 million question, huh?
I still haven't found the easy answer book. Part of the issue, I think, is how do you have relationships with people that it becomes comfortable to talk about whatever needs to be talked about. And like I said before, I'm usually not good at beating around the bush, so I just point blank talk to folks about it. And it might take more, again, it takes more than one time. But I've just, usually when people tell me they got a terminal diagnosis, I'll wait at least 2 minutes and then start talking about what do we need to talk about. And just keep filing what people say and go back to it.
The Nike commercial said, just do it.
Yeah.
Well,
and we can't, and again, it's one of those realities of life. And what I usually tell folks too is something, you know, death and dying in our country today is like sex used to be. Everybody knew what happened, but nobody wanted to talk about it. And that's just one of the issues. And I'll also tell folks sometimes, Henry Nouwen's book, The Greatest Gift, the whole thing about that book is the greatest gift we can leave our family and loved ones is to share dying with them. And how does that play out in everyday life? And it's tough. But again, it's just on and on with the same topic and just filing things away and bringing up the topic, even though it's an uncomfortable topic.
And not necessarily waiting until people are dying or get the diagnosis, but I find it fascinating. I served, I've been ordained for 28 years and served in parishes for the first 25. Myself included, and all my colleagues were really, really good in congregations at talking about what happens after we die. We're really good at that. We don't like to talk about how we get there. So it's rare that you would ever hear a sermon about dying or death. You're going to hear about sermons about, afterlife, but not about dying or death. Our educational classes that we offer, bringing somebody in to talk about advanced directives, doing a course ourselves about funeral planning, doing conversation, bringing in different people to talk about, ethical questions at the end of life, so that the congregation to become one of the places where the conversation is normalized. A really radical thing would be every time you do premarital counseling, part of that conversation, along with financial planning and everything else you talk about, is end-of-life planning and advanced directives. Right then, so it starts off right off the bat. Here are the kinds of things you're going to have to be talking about as part of your marriage and as part of your life together.
I work in an assisted living community, and very often the families will come in and their parents or loved ones have the advanced directives in place, but not a DNR. I was wondering if you have any advice on how to approach that subject with these families.
Well, the DNR is the order that a physician writes to take your advanced directives, advanced care planning, and make it real time, make it an actionable order. Now, some of the advanced directives, see, that's the problem with advanced directives. When you got this living will, you got this 3 checkbox thing. It says do not do anything if I have a terminal diagnosis. Well, that leaves a lot of legal wiggle room, especially for physicians, to interpret what is terminal, when should I write that DNR order. So that is where things get a little bit tricky, is taking an advanced directive and make it into a order, like a DNR. It depends a lot on the physician, it depends a lot on your power of attorney and how they interpret things and how they want things to be done. Now, hopefully in Illinois, we're going to get better. We're not a good state for this DNR form. We have a DNR form that's frankly not very very useful or very understandable, and patients have to sign it. We are trying to change that on a state level, but that's going to take a little bit more time. So until then, it's just a matter of trying to empower the families to really use what's written in advance directives, or what the patients would want in sort of their situation, their scenario, in especially a assisted living or a nursing home setting, and saying, okay, I don't want, he or she wouldn't want to be in the hospital for feeding tubes. He or she wouldn't want to be in the hospital, and to have them tell that to the doctor taking care of them. It's a little bit challenging in our present healthcare system, but you just need to empower that conversation between the family and the physicians to try to get actionable orders written.
Sometimes, too, the families are very resistant to getting, having the DNR, so it goes both ways, that the families are resistant. And I worked with a physician several years ago who we went to visit an older patient, and he gave a very graphic description of what cardiopulmonary resuscitation involves. I think he went maybe a little overboard, but research is actually showing that when somebody sees a video of CPR or has statistics and a description of CPR, that then they really consider it, what it involves, that it is traumatic, not very successful in many places. But most people are getting their information about CPR from watching House or ER, and the statistics there are pretty much exactly opposite what real life looks like. But people don't realize that. So education, again, it all comes back to that.
Loretta? Few of us experience natural dying. We're not at the bedside anymore. As the doctor in the film said, it's been removed. We think we're supposed to die in hospitals, even though we say we want to die at home. 80% of us say that. And we, unfortunately, are basing a lot of decisions, including CPR and DNR, on what we see on television, which is not accurate. And I have a website called End of Life Inspirations, and there's a 40-minute video that I talk about creating sacred space, and in it is a 4-minute slideshow of 70 pictures of the last 8 days of my mother's life and the hours after her death in the care of hospice. And there are other photos where you will see how natural death is transformative. And I encourage you to go and look at these pictures, because we don't get to see this, and share them. The experience, and in hospice, we think of hospice as a last resort when it's a last reward. 35% of patients are there for less than 7 days. That's tragic. We have to change that. And until we start taking the taboo off conversations about death and dying, and leading by example, having our own, those numbers aren't going to improve. And we're missing, as everyone here has said, the incredible opportunities for personal growth by being present at the end of life.
Are there any other questions?
End of life inspirations, or if you Google .com. Yeah. And if you Google me, it'll come up also, Loretta Downs.
Being a caregiver, when you're with a person bedside and they're actively dying, and from the beginning of the process they refuse any spiritual support from the facilities, and they'll ask you at the end about God, as with the family not wanting that for their wishes, but the person in the bed dying asks you about God. What is it that you could say to them that would be appropriate, so you're not, getting the family angry at you or scaring the patient?
If the patient asks, my responsibility is to ask the patient, and the family has to choose how they're going to deal with whatever the patient tells them I said. It's not the first time I've had people angry at me, most likely. But the patient that's his or her, if the patient's desires to talk about those spiritual issues, that's what he or she wants, and that's my responsibility to go there.
Anyone else on the panel?
Yeah, I agree. I think that, healthcare's gone a long way to kind of putting up some barriers to real empathy in end of life. And, you know, it's not our job to go around telling people what we believe and that they should believe what we believe, but it's our job to create a space where a patient feels comfortable enough to share his beliefs. And most of the time, they really don't want an answer, they want someone to listen to them.
Mm-hmm.
And so to be able to create that space where you can just sit without your own agenda and to listen to what they have to say, you know, and if you really feel called where they're asking you, and I've had patients come right out and ask me, what do you believe? I will say, well, what my belief is this, but what's important is, what do you believe? And let's talk about that. That's really what they want to do. They want to explore all of that with somebody who's courageous enough to sit there and listen to them.
Any other questions? Lynn? Oh, hang on one second, because we're having a hard time hearing you. Yeah. Thank you, Marjorie.
One of the things that really that struck me with the movie and your discussions is saying what's important to you, what makes life worth living. Well, how do you apply that to patients who have dementia or Alzheimer's? Because by the time, you know, they can't express that life is no longer worth living, but yet, you know, my mother had it for years, and so when she finally died, I really didn't feel a loss because I had lost her a couple of years ago, and I'm afraid that I'm going to end up like that. And I mean, you can't, I mean, euthanasia is illegal, so as long as someone is alive, even if life isn't worth living for them anymore, there's no way to address that, right?
Go on.
Well, I think that's one of the importance of having conversations really, really early, is to understand what your wishes are before you get into that state, if you're in that state. But the other thing is, once someone's in that state, is you can usually tell what makes them happy, what gives them a smile. And even though it may be totally off the wall and totally confusing and totally, you know, you don't know why they're smiling for it, that's you could sort of take that as, well, that's what makes their life happy right now. It could be watching cartoons. It could be something that simple. So that's where you would focus your attention and your care to, if you don't know, if you haven't had that talk with someone who's in that demented state, is what makes them happy. It could be just, you know, watching old movies. It could be listening to rock and roll. But what puts a smile on that person's face? And what puts a frown on that person's face? That's something you shouldn't be doing.
Mm-hmm. Yeah, and I think what, you know, I had a family member tell me a story about her journey with her husband who had dementia, and it was really profound for me. And I think one of the biggest challenges that we have as, you know, family members, caregivers, is that role that we've had with that person now with dementia has changed, and we are really attached to who they used to be. And if we can learn to give up who they used to be and have a relationship with them who they are now, it can be much better than we anticipate. And this woman, and this is what she taught me, she said to me, you know, he did die, and she said, I feel like I've lost him twice, because I lost him when the dementia really got into full swing. But then I had another relationship with him that was entirely different, and we really enjoyed it, and now I've lost that again. And she taught me so much with that, and I think that's, again, our own lessons through all of our life experiences, is we have to let go of our own agendas and then look at that person and meet them where they're at. It's like if you had a child. You need to meet them where they're at, not where you want them to be right at that moment, and then go on the journey with them from that place forward.
And especially if we're thinking about our own futures and we have some disease process or history in our genetics that we think this could be likely, is a couple of things. One is not obsessing about it so that we miss life now. That's on the one hand. But on the other hand, doing the work now of making sure that we have a POA that we trust, making sure that we're having conversations with them so that they really understand the essence of who we are. So it's like the chocolate ice cream conversation, the I love sunsets conversations, the I really like rock and roll, do not play classical music for me or I'll hurt you conversations. The fuzzy slippers, kind of like my feet cold conversations, all of those things, so that those become a part of, that they know us as well as they can possibly know us and are willing to be on that journey at all the twists and turns. And also having some conversations, maybe some of the conversations, but also writing and journaling. Okay, what scares me about this? What am I afraid of? What don't I want to happen? Making sure that we're writing and recording that, so even if we don't feel like talking about it, they've got a place to access some of that stuff, and we can really have the peace of mind of knowing that we've got some folks around us that are as well prepared to accompany us on the journey as they can possibly be. And that's a gift, not only protection for ourselves, but a gift to them, because they will really feel empowered. It's like, I'm ready. I don't want it to happen, but we are ready to really make this journey the best thing that we can possibly make it.
I just want to add, one of the things that really struck me on this movie is, I forgot who mentioned this, but how we view babies, and they're incontinent and they're totally dependent on someone, and we think that is awesome time, and we get sad when they grow up and they start fighting back, and the terrible twos and stuff like that. So we grieve that time of loss when they're a baby. And the viewing the end of life very similarly. It is a birth. It is a rebirth. And people, demented people especially, act just like babies. But you gotta somehow view that as sacred time and get, like Eileen was saying, get to know them in a whole different light. Just like a baby, getting to know a baby and getting to care for a baby. I think that's a beautiful thing, to view that part of life as that type of a sacred time in a person's life.
Loretta?
We've just heard some immense support for the spiritual part of end of life, not only for the person who's dying, but for those around us. But also we need to be mindful of the biological process of death, which we're also so removed from. And one of the key things is that we stop taking nutrition. It's like plants and animals in nature, when they've come to the end of their life cycle, they stop taking in nutrition. And one thing a lot of people do at the end of life, particularly people with dementia, is they don't want to eat anymore. And we tend to want to feed them. When part of this closing of our bodies and building of our spirit is not taking in nutrition. And I'm having right now in my own family, someone I'm very close to is in stage 3 Alzheimer's, and I was the flower girl at her wedding. And so this is, I've met a lot of people in end stage dementia, but this is the first time, and she doesn't want to eat. And her family is just trying to bulk her up, and I think it's her way of making a choice and a decision about how she wants her time to be spent. So we need to be evaluating the way we look at the physical aspects of dying, and understand that there are, your kidneys shut down, and it doesn't mean you need dialysis. It means your kidneys are shutting down and you need to call your family and start eating all the ice cream you can get down, and or your liver is slowing, all these things. We need to be mindful that there is a biological process that is natural.
End-of-life education is obviously needed, and we all commend each and every one of you for attending today. There are wonderful resources out there, but we don't talk about them. I encourage each and every one of you to please join the listserv for the Chicago End-of-Life Coalition. It's people who get it, who may be able to give you a trick of how they were able to get something done in their family. It takes a village to raise a child, and it takes each of us to educate each other on a subject that none of us want to talk about. I thank the panel for their talent and their time. And I remind each of you to please complete your evaluation form. And there are 2 certificates outside. One is a certificate for attendance for those who do not need continuing ed, and a certificate for continuing education that you'll receive upon turning in your eval. Thank you very much, and spread the word so that we fill the auditorium for next year.